Everyone. Good morning, Professors Şahin and Reci. Welcome to the Tassiszaal here in the heart of the University of Antwerp and also in the heart of the city of Antwerp for the conferral of one, or maybe two, of the honorary degrees for 20 and 22. My name is Anke. I'll be your hostess this morning in this beautiful location. And I'm grateful and delighted to be surrounded by so much knowledge, hard work, and incredible intelligence. Honorary doctors Uğur Şahin and zlem will shortly be teaching a masterclass titled The mRNA Evolution in Medicine. During the masterclass, you can ask questions using the chat function on the YouTube channel. This is for the people watching at home. After the masterclass, there will be time for a Q&A session in which Professors Şahin and Reci will answer the questions you submitted and also, of course, the questions of you here in this room. Then we will proceed to the conferral of the honorary degree. But first, I would like to give the floor to Professor Guy Hubens, Dean of the Faculty of Medicine and Health Sciences, who will offer you an even warmer welcome.
Dear Doctores Honoris Causae, Professor Şahin and Professor Reci, Your Excellencies, Ambassadors of Germany and Turkey, and Consul General of Turkey, Rector Herman van Goethem, distinguished colleagues, guests and friends, and dear online audience. A warm welcome here in these beautiful surroundings. This historical site gives you a warm welcome. It is not very often that one has the chance to meet people who really make a difference. Make a difference not in our daily work, but also in our daily life. I think, dear people, that today we are very lucky in that we not only meet one, but two of those people. Again, welcome and thank you. What a journey you have made these last 2-3 years. Faced with this terrible outbreak, this sudden outbreak of the coronavirus, you managed to find a solution for this pandemic in a very short time. It must be an Olympic or world record. Only 9 months, the time of a pregnancy. You succeeded in finding a solution that allows us to be here, to be present in real life. As Dean of a Faculty of Medicine and Health Sciences, it's the treatment and the prevention of infectious diseases is one of our main fields of research. And I'm a very proud Dean. Last week, we saw the birth of our vaccination center, Vaccinopolis, led by Pierre van Dam, Professor Pierre van Dam, Vice Dean of the Faculty, and also present here. And today, we can celebrate you, the pioneers of the vaccination against this terrible pandemic. So yes, I'm a proud Dean, and it shows the importance we give to the prevention and treatment of infectious diseases in our faculty. You succeeded not only in creating a solution for this problem, but you managed also to give a meaningful expression to the mRNA for a large audience, including surgeons like me. So, thank you. Let's start the celebration, and I'm happy to present the promoter of this morning, Professor Zwi Berneman, Professor Emeritus of the Department of Hematology and former Chief of Staff of the service of hematology at the University Hospital. Zui, I think you will have a laudatio ready. I give the floor to you.
Dear Doctores Honoris Causae, Professor Uğur Şahin and Professor Özlem Türeci, Your Excellencies, Ambassadors of Germany and Turkey, and Consul General of Turkey, Rector van Gouten, distinguished colleagues, guests and friends, and dear online audience. With this honorary degree, the Faculty of Medicine and Health Sciences of the University of Antwerp pays tribute to Professor Şahin and to Professor Türeci for their pioneering work in the development and implementation of the messenger RNA or mRNA technology in medicine in general and in immunotherapy and vaccinology in particular. The mRNA vaccine that they and their BioNTech company have developed and produced was the first one against the COVID-19 infection, and thanks to its top activity, it has protected the health and the lives of millions of people worldwide. In order to bring about this achievement, both Professor Şahin and Professor Türeci followed a highly original and creative path. Both of them became doctors in medicine and have been active since practically 30 years in the fields of oncology, hematology, and cancer immunology. Their striving to develop new immunotherapies for cancer patients led them to leading positions at the Johannes Gutenberg University in Mainz, Germany, and at the Association for Cancer Immunotherapy, CIMT. Very early on, they focused on the use of mRNA coding for tumor-associated molecules for the stimulation of the immune system of cancer patients. In order to advance the progress of this research, they founded the biotechnological company BioNTech in 2008, of which Professor Şahin is the Chief Executive Officer and Professor Türeci the Chief Medical Officer. Together with this company, they developed the technology to produce clinical-grade mRNA that is somewhat resistant to degradation and to place these mRNA within injectable fat particles, actually developing vaccines to treat cancer patients. Thus, originally, Professor Şahin and Professor Türeci are cancer immunologists and cancer immunotherapists. They also understood very early on that mutations that can lead to the stimulation of the immune system are not the same in all cancer patients. They then tailored their technology towards the differences between patients. In other words, they became actors in the development of personalized medicine, where the mRNA therapeutic vaccine is different from cancer patient to cancer patient. But the identification and production of individualized, personalized mRNA for each cancer patient takes time. So they set up their BioNTech company to be able to perform all these tasks in a very rapid fashion. They are still pursuing this approach for personalized mRNA cancer vaccines in order to stimulate the immune system of patients against their cancer and thus to improve their outlook. Then came COVID-19 with its procession of misery, death, disease, and disruption of society and economy. To their eternal credit, Professor Şahin and Professor Türeci and their collaborators understood that the powerful machine that they had developed at BioNTech could serve to mass-produce single mRNA vaccines against this horrible infection. In less than a year, their mRNA vaccine, now known as the BioNTech Pfizer Comirnaty vaccine, was developed and proved to be highly protective against hospitalization and death. This was a watershed moment not only in vaccinology, but in all of medicine, because it introduced the use of mRNA as a highly effective therapeutic agent. The field that Professor Şahin and Professor Türeci have pioneered is here to stay, and not only in vaccinology, and it is bound to have a glorious future in medicine. For all these reasons, we are deeply grateful to Professor Şahin and Professor Türeci for having accepted this honorary doctorate from the University of Antwerp and for giving us a masterclass today. I now invite Professor Şahin to the podium to give the first part of the masterclass. Following this, Professor Tureci will continue with the second part of the masterclass. Professor Şahin.
Dear Excellencies, dear colleagues, distinguished guests, dear Svi, it's a great pleasure to have this this chance to be here today and to talk about our research. When we got the call for the honorary doctorate, I was extremely happy, and this has many reasons. One of the reasons is that we share the passion for mRNA for more than 20 years now. And what I would like to do is to give you an intro about our journey, which is also in part the journey of the scientific community. So we started about 25 years ago to work on mRNA, and the motivation for that was, at that time, we were able for the first time to identify tumor antigens. That means structures which are different on tumor cells. And the idea was, at that time, it was the early beginning of molecular cancer vaccines. The idea was that we could use this cancer antigens which were discovered and stimulate the immune system to get very strong immune responses. On the right side, you see the idea that if you have a tumor-specific antigen, you might get an immune response, and the immune response would not harm the normal tissue, but would harm the cancer. So that was our common vision, and we were, of course, not alone, because a number of scientists were working on that. But what we early on understood is that there are several challenges to pursue our vision. One challenge is that tumors in humans, even if they are small, even if they are 1 centimeter, they are billions of tumor cells, and you have really to get an extremely strong immune response. And we realized early on that the immune response with the existing vaccine technologies is not strong enough, so we had to overcome that. The second is we understood early on that every tumor is different. Every patient has a different tumor. So that means if we want to make a vaccine, we need to change the vaccine for every patient. So that means we need a versatile technology. And the third aspect was that we understood if we want to make a vaccine for every individual, we have to do it fast. So we had these three challenges, incredible challenges at that time. But we were young doctors, and we said, okay, we have time, let's work on that. So we started to work on DNA because DNA was at that time on vogue, but we understood at a certain, after doing a number of experiments, that DNA will not work. And in 1996, colleagues published a paper, Eli Julibora, showing for the first time that mRNA, if loaded on dendritic cells, could induce immune response. The immune response was not very strong, but it showed us that it could work, and we started to do our own experiments and realized directly that mRNA could work. So the idea was take the mRNA, put it on cells, and in dendritic cells, and then use the cells for vaccination. And we were not alone with this idea. The colleague here, Svi Bernemann and his colleagues, had also started with the same idea. And actually, they published their first results before we have published that. One of the papers that very much stimulated us is the blood paper from Tenderloh, and Bernemann, and we saw the paper and discussed that, and we were enthusiastic about the transfection rate, about the stimulation of T cells, and we knew it's going to work. But we said it's still not compatible with our approach because you have to get dendritic cells, and it took time. So our vision was, and this is in the bottom depicted, to use mRNA and directly inject it into patients, and thereby overcome the limitations of cell therapy. But we knew at that time point this is not going to work because the mRNA is degraded too fast. That was the first challenge, and therefore our idea was to generate optimal mRNA. We had no clue when we started what is optimal mRNA, but we knew that we have to improve the stability of the mRNA. In the years thereafter, and it took us several years to understand how mRNA is degraded in the human body. And you can see an mRNA molecule on the right bottom side. It has many elements. It has not only the part where the information is encoded for the tumor antigen, but it has also several additional elements. And we learned that these additional elements are extremely important, and that we can modify them, and change them. And the science behind that is very simple. If we identify an element which is improving the mRNA stability 5-fold, and if we find another element which is also improving the mRNA stability 5-fold, we sometimes observe a 25-fold improvement if we combine that. So we did independent modifications, and we called that optimized mRNA, the backbone modifications, and this ended up in highly stabilized mRNA. And that was one of the first findings which were important to stabilize the mRNA, because the longer the mRNA is translated, the better it would induce an immune response. The second discovery that we made is that it depends on where the mRNA is injected. So we wanted to bring the mRNA to dendritic cells, and dendritic cells are everywhere. You can find them in the skin, you can find them in different organs. But when we injected the mRNA into the skin or into the muscle, we did not see strong immune responses. But when we inject the mRNA into the lymph nodes, we see extremely strong immune responses, much, much stronger, and we could reduce the dose. And we asked the question, what is happening here? So we took out the lymph nodes in mice and investigated them. And in the red color, you can see that in these lymph nodes there are a lot of T cells. So we had a massive expansion of T cells within 3 days. On the right side, you see a control mRNA, which does not code for the right antigen. And it was very clear for us, if we bring the mRNA to the lymph nodes, we could have a powerful vaccine, much stronger than in other places. But this is, of course, not suitable for vaccination of patients, because we need to use ultrasound, and this is still not the best treatment. So we tried to understand what is happening, and we saw that the mRNA, when injected in the lymph nodes, ended up in dendritic cells within minutes. So these cells were able to take up the mRNA within minutes and translated them and made the strong immune response. We tried to understand what is the mechanism behind that. And we understood that the mechanism behind that is an active mechanism, which is called macropinocytosis. This is the way how dendritic cells take up material from outside. And the fascinating element is that even though these molecules are huge, they somehow manage to go through the cell membrane and go enter the cells. We asked the question, can we get this without injecting mRNA into the lymph nodes? So we started to work on nanoparticles. So we took lipids and combined these lipids with the mRNA, injected that into the bloodstream of mice, and investigated whether this end up in dendritic cells. And it didn't. But we investigated that further, and after several years of research, we found that certain particles with certain physicochemical characteristics really were taken up only in dendritic cells in mice. So this was the finding in mice, and we got, again, extremely strong immune responses, but this time without injecting the mRNA into the lymph node, directly into the blood, and this is much easier, and this is clinical practice. So we translated this approach into the clinical setting, and we founded a company to finance that. This is BioNTech. That was the reason why to start a company, not because becoming entrepreneurs. It was because of financing our clinical trials, and could confirm that this vaccine now, an mRNA optimized in a lipid nanoparticle, could induce extremely strong immune response, not only in mice, but also in patients. And some of the patients, about 30% of the patients, had objective responses with shrinking tumors. And this confirmed that this is going to work. But this was just the beginning, and we wanted to go to the next step. And the next step is that every patient has a different tumor. And the reason for that is tumors occur by mutations, by by sequential mutations. And this is a random process. So that means every patient has different random mutations, and every tumor is different, and the only way to address that is to make for every patient an individualized vaccine. And we said, okay, let's come up with a method that could allow us to do that. And this was possible only to start this project was only possible in 2008, 2009, when the first sequencing machines arrived in Europe. So we got the first sequencing machine in our laboratory, and 2 days later we started this experiment. So we analyzed the tumors from mouse, identified the mutations which could be recognized by the immune system, put them into an mRNA, and we not only put one mutation into an mRNA, but we put multiple mutations. You can put up to 20 mutations into the same mRNA. And when we vaccinated with that, we could see we get mutation-specific immune responses. So, and every tumor has different mutations. So that means you have to do for every tumor a different mRNA. So it sounds like a lot of work, but the power is it's a universal technology. That means get the tumor, do the sequencing, make the mRNA, give it back to the patient. So we started to test this approach in a clinical setting, and this is shown here. It just shows that we get a sample, blood sample and tumor sample from the doctor. We do the sequencing. We compare the normal DNA, which comes from the blood, with the DNA which comes from the tumor, and everywhere where there are differences, these are mutations. We identify the mutations. We look if these mutations are active by checking the mRNA of the patients, and then we use computer programs to predict the mutations, because some patients have thousands of mutations and we want to get 20 or 10. So we have prioritization algorithms to pick the best mutations, and this is also a new research, neoepitope prediction. And then the computer suggests the mutations, and the experts validate it and say, okay, I'm okay, the computer didn't make a mistake. And then we produce the vaccine which encodes multiple mutations. We did that, and the results were very impressive. We saw if we immunize the patients with its own mutations, then we get immune responses. And these immune responses were not existent before vaccination. So that means we were able to make the tumor visible to the patient's immune system. And that's what a vaccine does. It's the same principle for coronavirus. And we saw that these mutations induce really very strong T-cell responses, much higher than observed before. And we were now in the ballpark having a strong enough immune response which could help us to control established tumors. And indeed, in our first clinical trial, we saw that patients who were vaccinated had, after vaccination, dramatically reduced metastatic relapse rates. So the red triangles show the metastasis in the patients before vaccination, and every line is a patient. And in total, these patients had 27 metastatic relapses in the 2 years before vaccination, and after vaccination, the metastatic relapse rate dramatically dropped. So our working hypothesis at the moment is that if we vaccinate patients, we could prevent metastatic relapses, which are the most important reason why patients die. So this is now clinically tested in several studies, and this opened up, of course, not only the research of mRNA, but it opened up the research of which mutations are the right mutations to take. So we call that neoepitope prediction research. It is a new field in cancer immunology. Bioinformatics, machine learning is used here, and we learn more and more, because every patient had different mutations. We need rules, computerized rules, that can be used for selection of mutations, and this will help us with continuous improvement in a few years to predict with a high accuracy the mutations which should be used in such vaccines. So the approach is extremely complicated, and you can see that this is a flow chart for our clinical trial in 2014. Yeah, and it just shows you the processes that are needed from arrival of the sample, sequencing of the getting the DNA out of the sample, the RNA of the sample, the sequencing, the prioritization of the mutations, and everything is an SOP. Yeah, SOP are painful. Yeah, you have to stick to them. It takes a lot of time, but you have to do that. Clinical trials are based on SOPs. And before starting the trial, we were audited by the regulatory authority. And you can see on the left side, this lady was preparing for the audit, and these are the documents. And luckily, the auditor was happy, and we could start the trial, and every vaccine was produced. And it took, of course, at that time point, with all the paperwork and all the pipetting, everything was done manually. It took us about 3 to 6 months to get the vaccine for individual patients. But having a company allowed us to start to work paperless. So everything was digitalized, yeah? And we could then use the computer algorithms to help us for the manufacture, and we use also semi-automation so that the steps could become shorter, and we were able to reduce the process to less than 6 weeks, in average 5 weeks. Yeah? And this was the status. This was the status end of 2019. Our aim for 2020 was to use this approach for multiple clinical trials. And then the world encountered a new challenge. Özlem will continue.
Yes, so let me fast forward to 2020. As you have already heard from Uğur, at that time we had already plenty of experience with mRNA. We had an mRNA toolbox. We had clinical experience, manufacturing experience, and we had already treated hundreds of patients with this individualized approach, so that we had went many times through starting with a unknown sequence and going through an entire process and having a vaccine ready on demand and tailored to the sequence. And this was then the situation when, at that fateful last weekend in January 2020, we realized that the world was actually already in the midst of a pandemic, and where we realized that we have something with which we could help to respond to this upcoming global crisis. What we did not know was how fast this would be. Would we have more than 3 months before the world population would be decimated? Would there be time to develop a vaccine in time? We did not know that, but what we did know was that time would matter, and that's why we called our program Project Lightspeed. We pledged that we would be as fast as possible without bending the laws of nature and of physics. So we started right away at that weekend to construct the first vaccine prototypes. We engineered 20 different vaccine versions against the spike protein of SARS-CoV-2. The genetic sequence was just released because, again, there were so many unknowns, and we did not really know what type of mRNA vaccine would work and which exact part of a spike we would need. We funneled all 20 candidates through preclinical experiments, evaluating them. We chose the most convincing 4 candidates for our phase 1 clinical trial, which started already in April in Germany. At the same time, it was clear to us, as always in a high stakes, high responsibility situation, you have to plan for success. There is no other chance. We did this by engaging into partnerships, forging alliances with Pfizer, for example, a company which has plenty of experience in large-scale clinical trials, large-scale manufacturing, and also rolling out out vaccines in all parts of the world. We also started to upscale at risk our own manufacturing capacities, and started the conversations with all relevant regulatory authorities in the world in order to ensure a communication channel. A couple of months later, in July 2020, we had our phase 1 clinical data, and based on that data, we could narrow down our candidate, and we were left with one candidate, which was the best of best, BNT162b2, aka Comirnaty. This candidate was entered into a global phase 3 trial together with our partner Pfizer, in which more than 40,000 volunteers were vaccinated in a randomized trial. And in November, we got the clinical data and could report that our vaccine indeed was not only safe, but also efficacious with a vaccine efficacy of 95%. And in the meantime, the vaccine is approved and authorized in more than 160 nations around the world, and in the meantime also more than 1 billion people have been vaccinated with our vaccine. So to give you a couple of glimpses from this journey, this is the vaccine which we chose at the end of the day, BNT162b2. It is based on the SARS-CoV-2 spike protein, which with two mutations is stabilized in an up position so that the antibodies, the immune response, can really reach the part which would engage with the ACE2 receptor. We have used all those modifications Uğur has described before. So the entire backbone here carries those elements we have identified in those years of work. And we use nucleoside modified mRNA because we had to combine with a new liposomal formulation, not the one we use in our cancer trials, which is administered IV. Here we need to administer intramuscularly, and this liposomal formulation brings already some immune activating activity, and therefore the mRNA itself is nucleoside modified. The formulation was developed such that it is, according to our development or design rationale, using the concept of leveraging hijacking of macropinocytosis. And this is also what we see when we inject intramuscularly. We get RNA accumulation, not so much in the muscle, but in the lymph node, in the draining lymph nodes and beyond. And the mRNA is translated there at high efficiency. So we get also with this concept the mRNA to the place where it should be. With this, we have entered, first of all, preclinical testing and have observed in mouse experiments that BNT162b2 does all those things we want to see. Namely, it induces antibodies against spike protein. These antibodies have a high affinity against the RBD domain, which is the part which binds to the receptor, and they are neutralizing, and not only antibody responses. For us, it was very important from the beginning on that our vaccine would also induce a strong T-cell response, and this is the case. On the left-hand side, we observe in mice strong CD4 responses, Th1 type, and strong CD8 responses as well. With this, we could enter the phase 1 clinical trial, and this was really exciting because immune responses in mice don't say much about what to expect in the human situation. So we conducted our phase 1 trial with a prime boost scheme, 2 doses of different dose levels of BNT162b2, 21 days apart, not time interval which immunologists like to choose. They like longer intervals, but in this case we were in a pandemic. We had to act fast. And what we saw on these different dose levels, we tested 1 to 30 microgram of mRNA, and this is pretty low. Thanks to our optimized mRNA, we could observe that in the 10 to 30 microgram range, we got a strong boost after the second dose, and we got high immune response levels, not only antibodies as such, but also neutralizing activity. And this was comparable to human convalescent sera in the higher doses, even above that, of patients who had been infected with SARS-CoV-2. So we had antibody responses, and they were neutralizing, which was already good news. What about T-cell responses? Also there, we could reproduce we had seen in mice, namely strong CD4 and CD8 T-cell responses in almost all immunized participants in our trial. And after the expected contraction, these immune responses were still considerable. You can see this by comparing it to conventional recall responses, CD4 and CD8 against CMV, EBV, and flu, and tetanus toxoid, that we had considerable T-cell activity. And with this, we could obviously go into a phase 3 trial where we compared in more than 40,000 participants worldwide, on the one hand placebo, and on the other hand 30 microgram prime boost 21 apart. And in November then we got this data, early efficacy data, which showed 95% efficacy against symptomatic disease across all ethnic, gender, age groups, 94% in the older subjects, and in the later data, 6 months efficacy data showed that this was a persistent effect. We knew that having a vaccine did not mean end of the journey, and that 2 important questions were at that time still, and also nowadays on our minds, namely how long would the immune responses last, and what about variants? And this is entangled, obviously, because an immune response which is persistent against the variant of yesterday might not be persistent against the variant of tomorrow. So what we observed, and also others, was that yes, antibody responses are waning, but T-cell responses are stable, and these are the ones which are of relevance for severe fatal disease and hospitalization. So what we also started at that time was that we installed a program which would allow us to monitor each new variant of concern. We did this by, for each variant when it came up, sera of subjects who were vaccinated with BNT162b2 to see whether this was still protective by looking for conserved T-cell epitopes, which were also of importance. And we also installed in November last year an AI approach, which was able to rank and assess upcoming variants. And late in November, we got a warning from our AI approach reflect Omicron, the Omicron variant, based on the fact that most of the epitopes were changed, in particular the important epitopes, which were important in particular for the neutralizing antibody response. So initial data showed us that for Omicron, different to the variants which came before, 2 doses were not sufficient, and therefore we proposed a third dose which reinstalls the neutralizing capacity, and in the meantime we also know that a 4th dose should be also proposed. What however kept us calm was the observation that all the T-cell responses, most of them were conserved between Wuhan, other variants, and Omicron, and this is the stronghold in particular against severe disease. This is also what the real-world data shows, namely that 2 doses are not sufficient, 3 doses are required to install immunity. As I said, we know 4 doses are also proposed, but it's also clear that we cannot just go on immunizing with the original vaccine, but now is the time point to think of adapted vaccines, and we are indeed have started already in November to develop an Omicron adapted vaccine which holds the Omicron spike protein. It's already in clinical trials, and we will get data starting in April to see what the effect is. What we can use a bit as a surrogate is people who are infected with Omicron breakthrough infections on top of their BNT162b2 vaccinations. And what we can see here is people who have been vaccinated once, twice or 3 times with our vaccine, and here the same groups 2 or 3 times vaccinated with an on top a breakthrough Omicron vaccination. So what we observe is that the Omicron breakthrough vaccination, which can be seen as a surrogate for an Omicron adapted vaccine, even in 2 times vaccinated people, but also in 3 times vaccinated people, restores Omicron-directed neutralizing capacity, but also broadly neutralizing capacity against all other variants. And this is also the case for breakthrough after 3 times vaccination. We looked into this in more detail. So why this broad immune response by Omicron vaccination, and we typed memory B cells, and what we can see is that an Omicron spike exposure on top of BNT162b2 vaccination in particular expands those memory B cells which recognize shared epitopes. So that we think this tells us a number of things, but one thing it tells us is that Omicron monovalent vaccine addresses not only Omicron immunity, but also in a broader way may induce immunity against a broader set of variants. And with this, I would like to briefly summarize. We have a vaccine which is potent, which also induces cross-reactive immune responses. Immune responses will wane, new variants will occur, and here we have the opportunity to boost and to develop variant-adapted variant-adapted vaccines based on our platform. And with this, I would just briefly only show those people who are the tip of this iceberg of a great team effort within BioNTech with our academic partners and also our partners at Pfizer and Fosun. Thank you for your interest.
So now we go for the question and answer session. And I have already one question from online. When could the Omicron variant-based vaccine be available?
That's a good question. So we started already in November, and to prepare the vaccine, and the vaccine is in principle ready, also upscaled and so on. We are conducting now the clinical trials the regulators want to see from us, and we will the first data available and start to submit in April, and we'll then see what the extent of data is sufficient for the regulators, but within a couple of months, we expect that we will.
Your past is a guarantee for the future, I would say. You know, I think we are all very helpful.
Again, with the speed of light.
We are trying our best. Yeah.
Are there any questions in the room in the meantime?
There's a comment.
Mm-hmm. Yes, just a minute, you will receive the...
Well, I'm simply an ambassador, have no science background or an expert, but I would like to actually simply express my gratitude to our professors for what they've done for the future of humankind, and I know what they did is greatly admirable for many aspects, but I also think what they did is a great inspiration for young generations. When I say this, I speak from experience, personal experience, because my daughter is also in this kind of academia, and she's been very much affected and inspired by what you did for the future of humankind. I think what you are doing is not only curing the people, but also inspiring the young generation, which is quite important. For that, I express once again my congratulations and appreciation. Thank you.
Thank you very much. Yeah. I have, I would say, a broad question, you know, which the epidemic, but also the vaccination have revealed quite interesting, I would say, sometimes not so pleasant, but interesting immunological phenomena. So how do you see the whole COVID epidemics evolve? How do you see? Is it completely parallel with the influenza, or is it going to be another scenario, or are there different scenarios? I know it's difficult. Churchill said it's difficult to predict the future, you know. Crystal ball, but you must have some ideas about that, you know.
Yeah, I can take. So there are some similarities with influenza, but there are also clear differences. The similarity is that influenza is also coming with new variants, but the way how influenza creates these variants is different than from coronaviruses. Influenza really comes with a completely different variants. And what we see now here with all the variants for the coronaviruses, they continue to evolve, yeah, from an ongoing evolution. Yeah? And so coronavirus is now with us for the last 2.5 years almost, and it has never gone. Yeah? Influenza goes away and comes back, yeah? Shrinks, but it never is so. And therefore we have to be careful to just take the learnings from influenza and say we are just doing the same now for coronavirus. We have to be mindful. We have to be mindful how our immune system works. Our immune system activates memory responses first, and we have to learn how to design vaccines for new coronavirus variants. What is the clear learning is we can get immune responses, but we also know that antibody responses wane over time. Yeah? And this is not an insufficiency of the vaccine, it's just how our immune system works. Yeah? It's like everyone. So if you stimulate the immune system, it has the attention, and if there is no additional stimulation, it does something else. So and these are the learnings. So we believe that with these learnings and with the faster vaccine development, we might be able, yeah, to control the future, but we have to be careful because the next variant could be more dangerous, yeah, and we need to be prepared.
So, how often do you think we need booster vaccinations? It's a question that many people are wondering.
Do you want to answer it?
Again, crystal ball, difficult to predict, because as I already pointed out, this is entangled. On the one side you have a waning of immune responses, on the other side you have variants which come in which pose a new challenge for the activity of the immune response. At some point we will probably enter into a stage where we will have a flu paradigm, so that for each season we would probably vaccinate and adapt to the respective variant which is there. But until we get there, it will be very dynamic, because each newly upcoming variant can pose an acute situation where the previous immune response is not working anymore.
Okay. I see that Professor Van Dam has a remark or a question.
Good morning, and let me first congratulate both of you. I'm Pierre Van Dam indeed, and we were so pleased to launch our new infrastructure, Vaccinopolis, where we could do challenge studies also in the future. But I have a number of questions. I will try to limit them. But first of all, I was wondering whether you would consider to make your vaccine an adjuvanted vaccine, or a more adjuvanted vaccine, to have a more sustained presence of antibodies, whether that would make sense, yes or no. And I would like to know what you think about the intradermal administration of your current vaccine, which is not really adjuvanted, as we would say, with the traditional adjuvanted vaccines. I would like to have your view on that. Thank you.
Thanks for the. So we are working on modification of our vaccines. So we are testing stronger expression of the spike protein, different versions of the spike protein, universally antibody-inducing variants which of the vaccine which induce more T-cell responses. So this is ongoing research, and of course we do incremental improvements. We ask also the question: can we get a stronger mucosal immune response? Could it be possible to have an oral vaccine? So this is all ongoing, but the route of application is at the moment not indicating us that we get a prolonged activity. With regard to certain adjuvants, they may prolong the T-cell stability, but antibodies will decline over time. So that's what antibodies do. The mammary responses are stable, but the antibody titers decline over time.
Peter Piot.
So I'm Peter Piot, and affiliated with the university here, but also special advisor to President Ursula von der Leyen. So great to see you, and thanks so much for all this amazing work, and also for continuing the work, because I think that's it's only the beginning. I'm very interested in what you announced in Marburg, so for collaborating with Africa Center, development of or manufacturing in Africa, and through this quite original setup. So can you share some of that for the audience and so, because I think it's another pioneering work from your side. Thank you.
Yeah, thank you for the note, and thank you for your work for the Commission. It's really important. So one of the frustrating moments that we had in when we came out with the vaccine is that we understood that regardless what we do, we will not have sufficient doses, and we know the challenges with vaccine equity. And we said we have to address the situation, and we addressed that in two different ways. One is really engaging into collaboration to increase the capacity of our manufacturing network. Our first plan was to produce 1.3 billion doses in 2021. Then we realized that the other vaccines are not coming, or several other vaccines are not coming, and we increased the capacity to 3 billion doses. And this was a genius engineering work of the manufacturing teams. They really managed to triple the production capacity. And in parallel, we asked the question, can we produce vaccines locally? Yeah? And everyone who knows how GMP manufacturing works knows that it takes usually 4 years until you build a manufacturing unit and then implement it and have this process there. And we came up with the idea to have a facility which can be cloned. So we started to work on the idea of container-based manufacturing. Yeah? So the idea of a container-based manufacturing is that you have a building which is based on containers, and in this building you establish a process. And once you have established the process and once you have approved it, take the container and ship it by train or ship or by flight and bring it, for example, to Africa. Yeah? And then you can clone the process. You can use the digital support to ensure the quality control. And then once it is established, within 6 months, you can get a new facility. So we call this biocontainers. And we now have a prototype version of this biocontainer in Germany. This prototype version will be moved in 2022, this year, to Africa. We have several partnerships now in Africa with Rwanda, South Africa, Ghana, and Senegal. Yeah? And the idea is, once this works, yeah, then of course, within a short time, you can transfer the process, and then you have this little, smaller manufacturing units, and small means you can still produce 50 to 100 million doses in these manufacturing units. Yeah? And so we believe that this could be a way to democratize access to vaccines.
Impressive.
If I may add there, another one part of this epiphany Uğur described was that it's not sufficient just to send something, even a container there. So another piece or pillar of our engagement is that we want to help to build an ecosystem at those places, because it's also about, for example, training people, education. The academic community will also become important in these efforts. So that's also part of the engagement.
Wonderful, wonderful.
So as the German ambassador to Belgium, I just want to congratulate you, first of all, for your amazing work. Secondly, this has all been a lot of effort of a team. You have shown it on your slides, how many people were involved. This has been a European, a Belgian, a German, a global effort. If you look in the hindsight, were there some moments where we could have worked better, where there could have been a better coordination, a better teamwork from the political side? Did you get all the support that was needed, or was there something we could have done differently? And if I understand it right, the vaccine was a sideline of your work. Your most work was on oncology and other stuff. So what can we expect in the next 10 years? Your war chest is pretty well filled now, as we have seen yesterday from your financial statement. So what miracle work can we expect in the next few years?
You take the second part, I start. Yeah.
Safe.
Yeah. Yeah, if you want to predict the future. So I think also in hindsight, the collaboration was fantastic. So what we have seen during the pandemic was something that we dreamed of but did not expect. It was a collaboration of scientists, yeah, of science and companies, yeah, of science with regulators. So usually you wait, if you submit your documents to a regulatory authority, you wait 3 months until they acknowledge they got the documents. and this time it was really different. We called the regulatory authorities and said, we believe this is going to become a pandemic, and we would like to have a meeting. And they told us, we don't believe that, but you can have a meeting next week. Yeah? And it was a rolling submission. So every time when we submitted, they gave us feedback on the next day. So it was an incredible collaboration. And what was also incredible, and you have seen that, is how the scientific community and the health community work together. Yeah, and it was good to feel this collaborative spirit, yeah, which made important difference. The question is, can we do something better against vaccine hesitancy? In the hindsight, it's difficult to judge that. Yeah? How you could avoid that some parts of the population are not willing to take a vaccine because of skepticism.
Before I answer the second question, just to add to that, important now is that we learn from all that, what we painfully have learned in the process, and install measures to build on those learnings, I think. So the second question was about miracles, and even though I feel Harry Potter-esque in this gown, I don't dare to look into the crystal ball. But I think what we can say is that this has shown the COVID-19 vaccine development has shown the potential of mRNA, and will be transformative, we think, for the field, as recombinant antibody technologies has been transformative. This is the same with mRNA, where you basically ditch the production fermenter, and the patient, the people produce for themselves the proteins they need in their body. And we want to contribute to this transformation. What we do is that we continue, and we have never stopped with that, our cancer vaccine and cancer immune therapy work based on mRNA. So it's not only vaccines, it's also encoding cancer antibodies and cytokines as mRNA and administering them. So this is one part, and we are in phase 2 trials there already. So sometime within the next 12-18 months, we will get data from those trials and then prepare for phase 3 trials. That's not the only field. We have extended our work in infectious diseases that will become a very strong pillar. We are looking into diseases like malaria and tuberculosis and herpes simplex virus. And we are so advanced that we will start clinical trials this year in those indications as well. And then there is an entirely different cascade of other diseases. Autoimmune disease, for example, if you can use mRNA to tell the immune system to attack, you can also tell it to hold back. And we have shown this preclinically and want to transfer this in clinical testing. And one last thing to mention is regenerative medicine, reprogramming with mRNA and rejuvenating with mRNA.
Very exciting, very exciting. There was a question.
We have a question.
Since you were already talking about the future and you already mentioned this, I had a question in my mind. Do you actually know when you inject the mRNA vaccine on site, and obviously you want immunization, you want it to go to the lymph nodes, how much of the cells actually produce the protein on site? Because looking forward to gene therapy applications and...
Yes, this is an excellent question. So the mRNA is in lipid nanoparticles. These are 60 to 80 nanometers. They are pegylated. So relatively little amounts of the mRNA is directly injected, translated in the injection site. So they go between the muscle cells, and from the muscle cells they are transported by lymph vessels to the local lymph node, and the local lymph node has about 85% of the protein. But they continue also to travel, and particles could also leak a little bit outside. This is not dangerous because the translation is short. The mRNA is degraded within a few days, yeah? and therefore we have a situation which is as clean as we have with recombinant proteins, because if you inject a vaccine based on recombinant proteins, yeah, it will also leak from the muscle, yeah, to the periphery, and this is also the situation with mRNA. The advantage of mRNA is it does not contain DNA, it does not contain contaminating protein, so the immune system is really focusing on the spike and nothing else.
But anyway, you should be able to target it to stay on the site where you inject it.
It is
this formulation not, but with other formulations you may.
Yeah, it is possible that the mRNA stays in the place, but it is not. It's not a good idea. It should go to the lymph node.
No, it's not a good idea for vaccination.
Yeah.
It's for gene therapy. It may be.
For gene therapy, in principle, yes. But still, the challenge is every muscle cell is a different different. So it is not easy to get the mRNA to all the muscle cells. You need the space between the muscle cells is so small that traveling even of 60 to 80 nanometers particle is not possible. So for gene therapy, you need even further, smaller particles, so like AAVs. Yeah?
Okay, we should stick with viruses.
Yeah.
No.
And this is also, this illustrates that mRNA technology is a toolbox. So what we have presented today is optimized for the purpose of intramuscular application or cancer therapy. And for each purpose, we need an optimization, also for targeting muscles in big scale. And this is also what is going on, what we do in the background when we extend into other diseases, into other pathophysiologies.
Okay. I think I have one last question from the chat. Do you see any other applications for the artificial intelligence system that monitors changes in epitopes? Would it be applicable to other infectious diseases?
Yes. I think artificial intelligence at the moment is nothing different than what people do in their research. They try to predict something, predict epitopes, predict antibody escape, predict the structure of a protein, predict potential mutations, and we can build that on an AI platform and just make it faster and more accurate, and that is going to happen. There will be a lot of applications.
Okay. I think this will be the end of the question and answer session. We thank you very much for helping us look into the future.
Thank you.
Thank you so much, Professors Şahin and Reci, for your groundbreaking work, of course, and for telling us about it in the incredibly interesting masterclass. It is now time for the special moment for the official conferral of the honorary degree in Medicine and Health Sciences. After a short introduction video, we can listen to the second part of the laudation by Professor Zvi Berneman. After receiving their honorary degrees, Professor Şahin and Professor Reci will say a few words of thanks.
Dear Professor Şahin and Professor Reci, dear Uğur and zlem, it's not every day that we are standing in front of two distinguished physicians and scientists who have saved the health and lives of millions of people. Your careers and achievements are an encouragement to all of us. Your achievements are truly astounding. There is, of course, the pioneering development of putting the mRNA technology to large-scale use in medicine. But there is also the fact that in Belgium and in the European Union, around 70% of the COVID-19 vaccines are the community vaccines produced by BioNTech and Pfizer. This means that a large part of this audience, including myself, and a large part of the online audience, and a large part of the Belgian and European populations literally owe their health, and part of them owe their lives to you. This also applies to the US, South Africa, and Japan, where respectively 59%, 75%, and 94% of the COVID vaccines come, so to speak, from you. In order to achieve this, you not only have pioneered the technology and production at your BioNTech company, but you have developed a partnership with Pfizer, which has undoubtedly helped in the massive upscaling of the production. The Belgian side of the story, of which we are all very proud, is that the Pfizer production site in Belgium is located in Puurs, not farther than 23 kilometers from here. The rapidity of the method you developed is also astounding. It took you only 10.5 months to develop the Comirnaty vaccine. It has been in use now since not more than 1 year and 4 months, and it is already and also saving us from a humanitarian disaster by allowing the process of a return to normality with enormous benefits for society, economy, and mental well-being. For these reasons, I request that the Rector honor Professor Dr. Uğur Şahin and Professor Dr. Özlem Türeci with a honorary degree from the University of Antwerp.
Oh, yes. On the recommendation of the Faculty of Medicine and Health Sciences and by decision of the Executive Board, the University of Antwerp confers upon Professor Uğur Şahin, Chief Executive Officer of BioNTech, and Professor Özlem Türeci, Chief Medical Officer of BioNTech, the degree of Doctor Honoris Causa in Medicine and Health Sciences for their pioneering work in the development and implementation of the mRNA technology in immunotherapy and vaccinology, and based on this, in the development of the Comirnaty COVID-19 vaccine, which has protected the health and lives of millions of people. So this is the epitoga of our university. And here you have already a lot of diplomas, but this is a new diploma for you too. Congratulations. Before giving you the floor, I would like to say some few words. As a historian, I remark that our cities are linked through Plantain and Gutenberg. And our cities too are linked now through the scientific research of our university and your university, because sorry, Svi, for that. I didn't realize before that your paper with Stefan Tenderlo, you and your team... Wat zeg je? Vico. Okay. Yes, okay, of course. Was at the foundation of the mRNA vaccine, and we are proud that we had a part in this too. And we still have a part now in this through the large program that we are trying to develop. At one side, for instance, in the aspect of zoonose, where the president of our university sometimes goes to Congo in very tricky conditions, but he always comes back. And where also other colleagues are implied also with Vaccinopolis too. So we are very proud. Thank you very much for accepting this honorary degree, and I give you now the floor.
Yes, thank you very much. And it's a pleasure to now start with, prior to Uğur, with words of gratitude. And first of all, you are the ones we have to thank, and we want to thank our beneficiaries here at the University of Antwerp, that you find us worthy to be honorary doctorates of this university, which is very close to our hearts, as you have heard earlier, because we are soulmates with regard to our fascination by mRNA and by immunology. So it's a great pleasure for us, and we treasure it high that we are now, members of this community. Can we say this? Of this academic and also scholastic community. So thank you for that. I also want to thank, also on behalf of my much better half here, all those people who have supported us and supported, in particular, this grand cause that's even more important, of developing a vaccine. These are all our team members back at BioNTech, but not only back at BioNTech, we are part of also academic hub in Mainz and in the Rhineland-Palatine region, and also those have contributed. So we want to thank all those, and we also want to express our gratitude for all members of our management board, for our investors who trusted that at the end of the day, something which would be worthwhile would come from out of a biotech company. So also to them, we are very grateful. With this, Uğur, I would hand over to you.
Yeah, I would like to continue with we feel extremely grateful. We feel grateful to be part of the scientific community. From our story, it is evident that we started not with zero, but we started with knowledge coming from other colleagues. And when we started, it was not just our own work, it was the work of our team, and we continued to learn from publications and work of others. This is how science works, and I strongly believe that science is the best what mankind has created, science and art probably. And this 2 years made this even clearer. So we have this aspects of evolving science, yeah, which was the last 20 years. But what we have seen in the last 2 years is also how we can, as a community, execute science and ensure that this teamwork, which is not only laboratory work, it's not only clinical work, but also the execution, for example, the successful vaccination campaigns. I have heard that particularly here in Antwerp, you had an extremely fast, light-speed vaccination campaign to convince the people. Yeah? And every time when I see one of my colleagues giving an interview in a newspaper or on a TV, I feel he or she is a member of my team, yeah, of the scientific team. And I feel this gratitude, and I'm proud to be part of this community.
I would like to finish this morning by saying a few more words of thanks, even though I think there aren't really enough words to thank honorary doctors Şahin and Reci for all the impressive work and for the inspiring masterclass, for accepting the honorary degree, and for, of course, for the COVID-19 vaccine, and also, maybe very personally, for keeping my best friend alive, because she suffers from skin cancer and she's treated by your immune therapy. Thank you. Thank you also to Rector Herman van Goetem, to Dean Guy Hubens, to nominators Wie Benneman, and to the Faculty of Medicine and Health Sciences. And of course, thank you to all of you for joining us this morning here in the room and also online. I hope to see you again maybe this afternoon at 3 p.m. for the last conferral, or otherwise maybe next year in 2023.